My name is Alex Fair. I run MedStarter Ventures. It's a venture fund. But we started out as a community. So I don't know if you've seen these jackets. It's called the Walk-In Gallery. And a whole bunch of activists, patient activists, doctors, people like Ron, people like me, people like Gail Zatz, who you guys saw yesterday. And there were like 500 of us. And they spoke before Congress. They got on lots of committees, people like Janae Sharp, just really passionate people. And this started like 11, 12 years ago. So I wrote this morning about us and then what's happening now. So I hope you guys like it. I'm not a poet, but sometimes this happens. We spoke truth to power and nobody cowered. Voices so loud, never too proud. Wearing our jackets, we made quite a racket. Believed we could drive change, but everything stayed just the same. So we created new ways. Some of them got play. Changing care, shortening stays, but where are they today? Eye triage bought by Aetna, Flatiron disappeared by Roche, Starling by Rom Hill, registered patient by MDON, and the list goes on and on. Disruptors disrupted by incumbents, just perpetuating the same dumb shit. Chrysalis cracking, verbally attacking, but that's not really all we're doing, because our returns are accruing. Now we invest in the best, teams that pass all our tests, rapidly grow, and soon they IPO. So we spoke truth to power, and nobody listened. Now we speak truth from power, and it makes all of the difference. So let's get investors aligned, no more disruptors sidelined. Change well begun, not nearly done. So stand up for change to fix all our pain from a system that's broken. The patients, doctors, nurses, and hospital leaders have spoken. That's it. L'chaim. Thank you. And I'm honored to lead a group of really amazing people. I am inspired by them every day. We have invested in a bunch of them. But if that comes back up, I can take you through some of them and some of the model. But we actually do test our companies before we invest in them. So all the companies you see today have gone through the ringer with us. We run contests and challenges. And like I say, it's doing pretty well. And that was after 3 years. So we're doing even better now. We had our first exit. We've got our next 6 teams coming into the accelerator in the program. And I think there's more slides here. But here's the people that we care about, not just the incumbents. We first asked the patients and the patient activists, people like Regina Holiday, the woman who painted this jacket and 487 other jackets, and was in that second slide. Those people like Ron. So those are the people that we ask, what do you guys think? What would you use? What would reduce physician burnout? We have this thing we call the 7AIM scorecard, which is the quadruple aim plus transparency, SDOH, and equity. And that's how we judge our companies, not just if they're investable and things like that. So it's a very different approach, and we think that we can change the world this way. So we've actually invested in 12 companies so far. Some of them are on the screen. And we don't just work with the patients, we also work with great organizations like Megan's here, so you guys are awesome. But also HLTH, and so if you've seen our shows and you've seen our contests for the AMA, we measure everything when they go on our websites or in our contests, things that nobody else has. So we've got big data on little companies, and it's why the model works so well. And also it's because it's not just me and my partners deciding, it's a large crowd of people. So we started as a crowdfunding site in the community, and now we do all that. But anyway, so I wanted to bring a couple of our really amazing people up to the stage. So Matt Gang, Matt Zachary, Ron Razmi, if you guys will all take a seat. And then we're going to go through some of the showcase of the medical innovations we found, which we think are disruptive and will continue to change the game. They've done really well. And as I said, some of them are planning their IPOs. Our first exit was actually from Direct Shifts. We took a partial exit when a big PE firm came in. Triage was our first investment. So if you're on an ambulance, it actually captures all the data in the ambulance, and it gives it to a heads-up display inside the emergency department, so they know what's coming. They're in over 200 hospitals, thousands and thousands of ambulances, and they're doing great. But after they won our contest, they went from 1 pilot to 12 hospitals that they were in, and they're just growing like gangbusters. Next slide. And then we actually have Karen Ware here, our Karen Ware team. If you guys saw the gown that I was wearing earlier before, where's our? We saw it. That's you guys. Yeah. Come on up here and tell us about Karen Ware. Do we have a hand mic for them? Where's the gown?
Oh, it's in
Somebody go get the gown. Shannon, come on up here and talk to people. Get the mic first. So they actually have 2 slides they put into the deck. Hopefully they got in there. So come on up. Thank you. Oh, one
Hi,
that
everybody. I'm Shannon, and my counterpart's Mon, and he's coming back here with our patient gown. But a little bit about Care and Wear. So we're a startup located in New York City, and our mission is to bridge fashion and function. So we work with healthcare providers, patients, and clinicians, and kind of create some of the best products out there that haven't been created yet. So the company originally started with our PIC line cover, which has expanded to our port access tops, our hoodies, and our patient gown as well. So we have Mon here who can do a little show and tell. But basically, we're kind of giving patients back that, making sure that they're satisfied with the products, and also we're working with clinicians so that they're really innovative. And Mon's.
Patients don't usually wear suits. Note the color coding.
So we have color-coded ties on the gown, and instead of having your backside exposed, it ties in the front. It's completely reversible as well. So also, if you do need to have the typical gown on, it works just as well.
So first question, what's different about this gown than a typical gown that we all wear when we go to get tests?
Yeah, so unlike your typical gown, most typical gowns, your backside is being exposed. So we're saving costs in the sense of, instead of putting on 2 gowns, of having your front, because a lot of hospitals put 2 gowns on patients so their backside isn't exposed, we're giving patients the satisfaction of having the comfortability of tying the gown on themselves and not having their backside exposed. But I can let Mom go into it a little more.
So you're saying it's a cost savings because they're using less gowns? Have you actually seen that in the hospitals that you guys are serving?
Yes, we have. This is loud.
Yeah.
So obviously there's the cost savings as far as linen usage reductions. A lot of the hospitals will, I guess pretty much every hospital will be paying for their gowns by the weight. So, you know, if the launders are weighing it as they come in and out, it's a direct cost savings on that end as well. We have found that these gowns actually weigh less than the typical hospital gowns either way, around 2 ounces less, we've heard. So that's a cost savings as well.
Does anybody want to try them? I wore it before. I didn't want to take it off.
Yeah.
But anyway, so
I think they also look more fashionable.
Yep, that's part of it.
It's nice to look good when you're in the hospital.
They've come a long way.
Of course. And part of the value that we offer to our customers as well is the branding opportunity.
Mm-hmm.
So this gown specifically has one of our customers' logos as part of the print. And that's, you know, as we've seen, a lot of the hospitals and health systems are becoming way more centralized, and they want to unify branding across their systems and sort of, you know, push their brand as a health system further as well. It's another opportunity there.
Is this a pain point for health systems and hospitals?
I guess that's a question for the audience. Does anybody here represent a hospital system anymore? Or did all the hospital systems leave? Okay. How about patients? Anybody a patient here? Do you guys like this idea? So just to repeat Kelly's question, she asked how matchy-matchy is it? Because everybody likes matchy-matchy. Are there non-skid socks that go along with this, or bed linens or things like that?
Yeah, so we are working on a non-skid sock as well. You know, as I guess you mentioned, the other linens, a lot of the hospitals will be purchasing their gowns as part of a greater linen package. And so that's another area that we're working to help some of our customers with as well, if they are buying them at scale and looking to get our product in for the gowns in the first place.
If I may, Matthew Zachary, former Albicom Google Health 2, 27-year cancer survivor. I live and breathe the 80s, so I like that profile. I will testify to Care and Wear because I first met their founder, Chet, who was here today, at a global trade show I hosted in Vegas called the CancerCon. I ran a nonprofit called Stupid Cancer, which was like the dominant influencer in the 2000s and 2010s in young adult cancer. And we had this massive trade show in Vegas that had 1,000 people come from all over the country. And he showed up, and he wanted to learn from the community what they didn't know they needed, what he didn't know they needed, and what they didn't know they needed. So forged from the embers of literal 1,000 people in Las Vegas over 4 days, this idea really became, it was the seed that came directly from listening to the people who, to what Elise was saying, the actual end user.
So what do you think of their creation?
It's terrible.
He's spoken.
I love that it's ideated. It's really, and the fact that they were able to blend it outside of oncology and other sectors, it really is, again, like, it's also like very traditional CPG, DTC. It's fashion with quotes, with an asterisk maybe.
Well, they actually have partnerships with Oscar de la Renta and a couple other designers.
Yeah.
Where's your product red version?
The red version?
The
Oh,
only one
sorry.
that
Can we
got
get
product
there?
red?
Sorry, we
We
don't,
don't-
get,
Charity.
we don't get it, man.
Yeah, so I guess to your point, all of our products we do create with a three-pronged approach where we work with patients, clinicians, and then somebody from the fashion side of things as well. You mentioned Oscar de la Renta. The patient gowns themselves were developed as part of a class that we taught at the Parsons School of Design, just here in New York. And so, working with different partners in the different, the gowns, they touch so many people. Across the hospitals, even outside of the hospitals, the laundries, and so really need to get everybody's input in how we design it, because that's the only way you'll actually get them into the hospitals is if you have sign off from everybody involved.
Have these affected patient satisfaction scores at your hospitals? Do you know
we
that?
have seen some evidence of that.
You should definitely document that.
Yeah.
Okay, so that's our first showcase company. What do you guys think? Anybody here want to talk to them?
Hi, I have a suggestion for you.
We love
So
suggestions.
many people in the hospital that are amputees, they have nothing really other than a really boring, ugly sock that they can put on an amputated limb. It would be really nice and fun if you could offer something like that, something that's a little bit more feminine for females and, a little bit, maybe not to go into the whole gender thing, okay, but something that's fun for them so that they can have a different type of experience while they're in a hospital bed if they're missing a limb. And there could be a lot of potential there for you with the VA or any other hospital, because that's something that's not offered right now.
Yeah.
Just
Yeah.
saying.
We're always listening to feedback
great,
and
Carrie.
adjusting our products. So that's one thing that I know our CEO really preaches, is that our products we're not sticking to one product. We're always trying to innovate, hear the end user's thoughts, and kind of putting the patient satisfaction and the end user process into the gown. So like when it comes to putting on the ties, you are now being able to tie your gown. You're not having someone tie, like having someone help you, like giving back that power and humanization of
Humanization.
thank you, of
Okay.
wearing the products.
You guys are doing awesome. Very proud. Happy. Great job. They won our 2015 Hospital Innovation Challenge, and we're very happy with what's happened to them. So, I always like to say, are they reducing the cost of the care? Are they making care better for patients? Are they increasing access? And they're definitely hitting of at least the triple aim, 2 of the 3 of the triple aim elements. Miami is one of our most amazing companies. They reduced the cost of care by 30% for patients with autoimmune diseases. Lupus, the founder has lupus. She actually was on high-dose prednisone. She actually got pregnant at 46, okay, because she got better from her app, but also tens of thousands of people have used it, and it's been really helping people with lupus, long COVID, lots of stuff. So, and they've also, since we invested, they're at 40 million now. So they've gone up about 80x. Depends how you count. So this is what I mean. Go from truth to power to truth from power, meaning now that we're investors, we can actually affect the changes that we dreamed of. Okay, so next up, I believe this is Direct Shifts, I believe?
Nope.
Who is this? Oh, sorry? Is Valera in the house? Yeah. Oh, thank you. Thank you for telling us you're here. Introduce yourself and take the corner of the stage, please.
Hi, everyone. I think I'm solo today from Valera Health. My name is Sarah Coiro. I'm an account manager with Valera. You'll have to excuse me. I have some notes. I've found out about this a little last minute, but I'll go over a little bit about our platform and our treatment model as well. So we're a comprehensive virtual mental health clinic, and we're comprehensive in the sense that we treat patients age 6 and up across a range of acuities. So ranging from mild to moderate depression, anxiety, through serious mental illness, which is kind of a differentiator for us compared to some of the other virtual providers. We're currently in 10 states right now, so all of the Northeast states, and then most recently we've expanded to Florida and Texas, which is really exciting. So we're moving to the West Coast as well. We're in Washington, Oregon, Arizona, a few other places. And we've seen really positive clinical outcomes across the 300,000 visits that we've done so far, which is awesome. And then we focus a lot on quality metrics and documenting the metrics. So initially our clinicians screen for depression, anxiety, and substance abuse using PHQ-9, GAD-7, and TAP surveys. And then we're also able to kind of track these survey scores over time and report any positive outcomes to our partners. We recently received our NCQA accreditation, which is awesome. And we're able to partner with hospitals to meet a number of their HEDIS measures as well, which is a huge priority. And then expanding access is also really crucial to our mission. So like most virtual providers are more of a direct-to-consumer model, we kind of partner with different health plans and hospitals to offer an in-network model, which is great. So that kind of helps us to reach the largest number of patients possible. And then in addition to working with commercial plans, which is how most virtual providers operate, we also offer our services through Medicare and Medicaid in most of the states that we have a presence in. And then that last slide kind of just went over our treatment model. So our care model has a team-based approach. We kind of go from therapists, and then if patients need psychiatrists for med management, and then for more high-risk patients, we also offer care managers, which is great. And then here's some of our metrics. Really low no-show rate. Obviously, it's a virtual provider, so it's a lot easier to get those numbers down. And then also really great depression improvement scores based on the PHQ-9 that I mentioned. So yeah,
that's pretty
excited
amazing
to be here.
That's great, Sarah. And it's really great to get the update. I mean, I've known Tom for 20 years. He's just an amazing guy.
He's
and
pretty
I'm so
great.
excited. How many visits are you guys doing a month now?
A month? I think we had 30,000
That's
last
amazing.
month. Yeah.
When we invested, they had 0. Are there questions from the crowd for Valera Health or one of our most successful companies, or from the panel? Go ahead, Matt. I think, don't you have a mic? You're mic'd.
Am I?
That's what that thing is. It's a mic.
I know one of the things that telehealth companies have trouble with is recognizing the patient's schedules and trying to figure out how to handle the ebbs and flows of the patient census. How do you guys deal with that function and making sure that you have enough providers to meet that patient demand on a day-to-day, week-to-week basis?
It's definitely a work in progress, and I will attest to the fact that that's a huge priority. We had about a 2-hour meeting about that yesterday, but we're making really big strides in it. We try to keep our providers like over 75% capacity just to make sure we're kind of utilizing everyone to the best extent. And then we also really try to get forecasts from all of our partners just to make sure if it's going to be a really large volume partnership that we're kind of staffing up for it. We do, if we do have forecasted really large numbers, we do kind of hire based on anticipated patients, which I don't think a lot of other startups do. So yeah, I think
So
if that answers your question.
Are your providers employed by you?
Our providers are employed. The majority of them are full-time employees. We have some contracted providers, but we have like 400 plus providers, most of which are full-time employees, which is a huge, we have LCSWs, LMSWs, and then psychiatrists as well, MDs. So I'm not sure exactly what the breakdown is for that, but I think that's a big differentiator too in terms of recruiting, because a lot of these virtual mental health companies are kind of contracting out employees, and they don't necessarily get salaries or benefits. So that's a big draw.
So access to care is very important to me. And I think mental health is so stigmatized. And I think something like only 1 out of 3 people with mental health issues actually seek mental health ever in their life, let alone every time they have an episode.
Right.
So how is Valera changing that? And how can you measure it even? Like you probably see utilization. Like you guys are written into, last I heard, 14 different insurance plans, probably a lot more now.
Yeah, it changes all the time. And I have the list of New York insurance plans if anyone's interested.
You should be in every plan, as far as I'm concerned.
Yeah, we're almost there.
Really?
New York's definitely our best
That's
state.
awesome.
Most of the major ones. But in terms of patient engagement, I guess initially, I think our in-network model helps a lot with access, simply because if patients go to their primary care doctor, they can immediately be referred to us as a resource rather than needing to find it kind of on their own. The doctors are really like equipped with everything they need to refer a patient to us. It's a really easy process.
Yeah,
So
the
I
barrier
think,
to entry is very low, right?
exactly, yeah.
It's just like Teladoc, but
Especially and I think another big one for us is that access is really important for us. It's like a key pillar of our company. So we offer over 13 languages. We have different specialties. And then, I guess that's kind of an overview of how we reach out to patients. And then each patient is also assigned kind of a health coordinator who makes sure that they attend their appointments. They just keep reaching out to them multiple times to make sure they attend. And I think that's been really helpful too. So
that's fantastic. It feels very good for me. And also it's reducing the cost of care. So we always welcome questions from the audience. So Juby George Vasquez, the question.
Okay.
She'll go.
I'm a clinician. I have set up these kind of stuff. So my curiosity is on this part. Stratification, you can have easy cases or moderately complex cases, but then there's the complex to severe cases. And do you have programs or things put in place to handle that? And that is also a problem of current times with the mental health crisis. I do not want to say the other words that I already said before.
Please, Juby, I think we understand the question.
Suicidal ideations, homicidal, and other types of those kind of severity. How do you navigate when it is a virtual situation? It could be somebody sitting, miles away and you don't know what town, county, police, whatever resources. How do you manage that?
That's one of the big reasons that we implemented the care managers or case managers, care managers. So if a patient is kind of flagged as being high risk or has some type of history, we also take any discharge documentation if they've been hospitalized. So they'll be connected with a case manager, and case managers are familiar with local resources, things like that. If a patient needs antipsychotic injectables, they can kind of connect them with a local resource to help them with that. So I would say the case managers are really helpful in that sense. And then we also try to keep the relationship pretty tight with the primary care physicians or whoever, the social worker or whoever referred the patient. So I'm in contact constantly with the health plan and social workers if any of our patients are hospitalized or any kind of episodes happen, or even if it's a high-risk patient who hasn't been showing up to their treatment or anything. So
that's awesome. So big round of applause for Valera Health, one of our fastest growing companies. Thank you, Sarah. Great job. You didn't come back. So next up, actually, is one of the guys on stage. And maybe I get to sit down for a second.
No,
Matt
please.
Gang, take it away. Yeah, you want to use this? You have to point it over at that thing over there. And
All right.
Give it a shot.
Thank you for having me and us. My name is Matthew Gang. I'm the VP of Growth at Direct Shifts. Our mission, or what Direct Shifts is as a whole, is we are a tech-enabled staffing platform matching clinicians with providers in all different types of settings, whether that is inpatient, outpatient, telehealth, so on and so forth. Our main goal and our ideology, our thoughts around what happens in the staffing environment goes way beyond just placing a clinician or a provider with a hospital or health system. It starts with that initial vetting process and making sure that a health system isn't just getting another candidate who has the right credentials, the right requirements, the right licenses, especially as I'm sure a lot of people have learned after the last 3 years. It's important to have the right provider or the right clinician in the right situation, because at the end of the day, that's what drives a positive patient outcome. So in addition to that initial vetting process, we feel like you're supposed to lean on the credentialing aspect of it, making sure that all of the I's are dotted, the T's are crossed, making sure that they feel like they have a true employer. A lot of the clinicians and the providers that are placed on contract work don't have coworkers. They work on 8-week, 13-week contracts, and then they pick up and they leave and they go somewhere else. So what we're trying to bridge is that gap to make them feel like they are part of a community, a source where they can get those benefits that while the staff at the hospital, the person that they're working with, has access to, they don't necessarily have that. The way that we place our clinicians or providers with hospitals is by using AI, in reference to the panel that was sitting up here before, in cutting down the vetting process and making sure that the clinician or provider has the right credentials that meet that job description that they are looking for. By doing that, it cuts down the time to fill, and by cutting down the time to fill, it adds to that top line revenue by the hospital or health system being able to see more patients on a day-to-day, a week-to-week basis. You were gonna say? Yeah?
Nothing.
Oh, okay. In addition to that, one of the major things, or one of the major risks that we try to mitigate as a company, is by making sure that the hospitals, when clinicians and providers call out, they go on sick leave, they go on maternity leave, for one reason or another, that hole that is created in those hospitals is covered. The approach that we like to take is by creating a float pool. So making sure that there are pre-verified, pre-credentialed clinicians and providers that are available on a moment's notice or on a day's notice to be able to go into work and cover the necessary shifts for the doctor or for the nurse or professional that has called out for the day. We see on average that a hospital or health system has about 10 to 15% of their staff call out on a daily basis. So if this float pool is in place, we're able to help them mitigate that downfall and keep those patient outcomes high by them seeing more patients.
That's pretty amazing, man. I've seen that. Let's just have a discussion about this. So one of the biggest things we've heard about here at this conference has been provider burnout. How is this helping provider burnout? Do you have any metrics around that?
So I think the main thing to recognize is that as stressed as these health systems are and as needed as these professionals are, they are human beings. So the approach that we like to take as a company is making sure that we are as proactive as possible in reaching out to them and making sure that they are okay. One of the metrics that we do track on a day-to-day, on a week-to-week basis is the amount of hours that they're working.
Can I make a suggestion?
Go ahead.
Talk to Sarah. Okay.
That's why I asked that's why I asked the question.
Okay, that's great.
So when we see a clinician or a provider that's working a significant amount of hours, that raises a red flag. We're not just going to sit there and say we think that they're averaging it out with the amount of contract hours that they're supposed to work. And, 1 week they're high, the next week they know they're going on vacation, so they're low. We see that as a red flag. That's a metric we track, and we proactively reach out to that professional to make sure that everything's okay, to make sure that they are not getting burnt out, because especially with the line of work that all of these individuals are in on a daily basis, it's easy to
it's the hardest profession in the world.
To be buried.
Do you guys have questions for Matt about direct shifts? Or anybody from the audience?
Yeah, I mean, I think one thing that comes to mind is this idea that you have shortages because we haven't trained enough physicians in the last 30 years. I think there's only been 1 or 2 new medical schools created in the US in the last 25 years. So not enough physicians. For a long time, we were filling the gap with foreign doctors who came here, did residency, but that's also way down from where it used to be. So question is, where are these providers coming from?
Yeah.
Because there are already shortages, you know, they need to be working, making money. It's not easy to go find nurses or doctors. And I see all these staffing companies around this. So how do you find enough supply to meet an ever-changing demand?
Yeah, great
and
question.
Good supply, like
exactly,
right?
100%. You know, I think the one thing that you just said, and it hits the nail on the head, is there's been this shortage for 25, 30 years now. And I think everybody's tried to just go on about their business in trying to mitigate and sweep it under the rug and go on with their day to day. I think, you know, starting with COVID 3 to 4 years ago at this point, this really put this situation under the microscope a little bit.
Right.
So to answer your question, you know, how do we stand out essentially in a saturated market to find these providers when there's a shortage naturally is, you know, going back to what I had said before, giving that community feel. Yes, we cater to our hospitals, but we also want to make sure that we're going beyond just finding the clinician or a provider a job. We want to make.
Aren't you leaving out the most important thing?
And what would that be?
So a typical staffing company charges 40% of the physician's salary. What do you guys charge?
15 to 20%.
Okay, so who gets that money?
We make sure that those savings are passed back to the
Doctor,
providers.
right?
Yep.
So they're making more money working with you.
Absolutely.
Maybe working less hours, not burning out quite as much. Right?
Exactly.
And who else saves money?
The employers, the hospitals.
Okay, so that to me would be the most motivating factor if I was a physician with you.
But I mean, what doesn't that mean? You have, I mean, I'm an investor.
Yeah.
I want to see a healthy profit margin for the companies we invest in. It sounds like you're passing on your profit margin to the doctor and the health system. That's a tragedy. If you're an investor.
Yes, but if these are automated, then it's different. This is why we invested in them.
I hear you, but at the same time, as a tech-enabled
Give me the money.
Yeah, as a tech-enabled services company, we're able to find that happy medium between volume, quality, and making them more financially efficient.
Do you think you have this sweet spot where you're helping the business model of the doctors and the providers, but also you guys are seeing more growth and more traction, even though you may not. Yeah. Okay. So that's your business.
So guys, can I tell us why you started Offscrip Health and what it does?
So I alluded to my jaded backstory a little while ago, but the gist of what I do and live in is in giving consumers what they never knew they needed. And I don't mean like a new flavor Doritos. I mean the patient space. No one knows what they need because no one asked to be there. It's the shit happens store. You didn't get a consumer report on buying a fridge. You're thrust into an ecosystem that no one cares about you unless they make money. And it's fraught with just dumb fuckery that doesn't put, again, channeling Elise, does not put the human being at the end of the needle as the primary reason for cost. A primary reason for an outcome. And the choices that you didn't know you needed are decided by other people. And ChatGPT is not going to do shit for this. I'm just going to chime in on that. It'll help your kid cheat on a science paper to pass the SATs or whatever, but it's not going to help any patient ever, and I want to be proven wrong. But I live in content. I've been a radio show guy since high school. I did public radio. I hosted the very first talk radio show online in the country for healthcare in 2007 called The Stupid Cancer Show. It was me every Monday from 8 to 9 live. Remember live?
Yeah.
Old enough to remember live. So we had about 4.5 million people listen to that show over the 500 episodes that I hosted it for. And it was a real case study in giving people permission to be pissed but a community to take leads from and learn from that aren't about medical decisions. They're about life decisions. And that has been lost in the noise of social media and videos, which I'm also sick of. I don't want to sit down and waste time staring at somebody when I can just hear them and get a better gist of what the hell I should do
Matt,
based on what they sound like.
You're starting to sound like a sort of a
No, I'm an
crotchety
old Jewish
man.
guy in disguise. I'm getting to the point.
Wait, what is your point?
If I don't start
Oh, you've got
dramatically,
the
no one
number
pays
one
attention.
podcast out there?
Like,
Yeah.
everyone that their heads of their laptops is looking up now. Be happy. The point is, radio is the new opportunity that should have been there all the time. And that's what I've decided to focus on after leaving the nonprofit 4 years ago. I wanted to prove, first and foremost, that listening, the art of listening and the art of telling, have been sorely forgotten in any consumer journey. Podcasting is at an all-time high in this country. So I wanted to start a production studio, a shop, a content shop, a film house for radio that did one thing better than anyone else, which is create stories. SaaS, stories as a service. I just made that up. You can own that. That's part of our portfolio.
It's SaaS. I've heard of SaaS.
Yeah.
Sassy. You need to have a Y
It's
in there, I
sassy.
think.
Fine. And we started with a simple premise that if you have something entertaining, and that's radio has to be entertaining. No one cares if you have a face for radio or not. Entertainment, infotainment, health attainment, what are buzzwords you want? That's going to reset the clock on giving people, oh, this person sounds like me. They're helping me believe that it's okay to be angry and giving me tools and life hacks to know shit exists. That was the fundamental premise. Is it possible to do that? And the truth is it is. So I have a show. We're a network of shows. But most important, we pioneered one specific thing, which is direct to consumer marketing of podcast miniseries and narratives. We work with professional public radio producers from NPR, Slate, PBS, CBS, whatever, and craft intentional narratives, knowing exactly who's going to listen in advance. And that is not media.
Is it healthcare focused?
No, it's all about sports. Yes, it's healthcare
Is it
focused.
healthcare focused?
No, I mean, it's exclusively healthcare.
It is exclusively healthcare. It is specifically pipeline driven. It is indication specific. It is zip code specific, culture specific. So 2 examples. We did a massive documentary in 2021. I would almost say it's required listening if you live in healthcare in any space, called The Cancer Mavericks, an 8-part This American Lifestyle audio series about the 50 years of citizen activism in America since 1971. We need to understand where we came from to understand where we are today, and no one's done that. 500,000 downloads being taught as pedagogy at 2 universities in media studies. That proved that there's an appetite in this country to understand why we are where we are, not what's wrong and how can we get out of it. 2, we produced a series for sickle cell. I'm a white Jewish guy from Brooklyn. I know shit about sickle cell, but we convened talent from public radio and from the community to produce a series called The Sickle in conjunction with a drug company looking for FDA approval for their product. And they needed voices. So we produced this series. 100,000 people listened to it, but all those people were from the sickle cell community. We used to talk about spray, pay, spray, pray. Let's hope people find this shit. We're done with that. We marketed that show based on claims data and household data to 5.8 million people in this country. Like we're Doritos, just spending money. And we had an acquisition of 52 cents a listener, a download. And then all those listeners were channeled towards the Sickle Cell Disease Foundation of America to support all the efforts and initiatives the country needed to get Bluebird Bio over the finish line.
So is this Medicare claims data you're using to target?
Yes, but here's the secret sauce. Medicare claims data has to be sanitized and neutered by compliance, which ruins everything. We live above that space. We are consumer, direct to consumer. We can say what we want, recruit who we want, no approvals. Because we're able to use the household data, and this is kind of weird, laid over the claims data to correlate CPG, household demographics, and psychographics, and then strip out the claims data, and to 90% accuracy, focus on regular advertising.
I know we're healthcare geeks, but that's a little bit too much of how the sausages
Sorry,
are.
my inner alcohol comes out every now and then. The truth, it doesn't matter in the weeds. The truth is we get the right content to the right patient at the right time, and because it's entertaining and fun and well-produced, they listen, they learn, and they take an action.
So it's a consumer podcast?
It is a consumer podcast, yes.
Well, actually, Matt, you have how many podcasts in your... So I think of them as like the Motown for like podcasts for healthcare.
28 shows in a series, over 1 million downloads in 4 years, and we have about $100,000 a month. So we've proven the point that if you give human beings healthcare information from people that sound like them, they'll do something about it. It doesn't replace decision-making and access and all these. It doesn't do that. It helps people feel empowered to learn what it really means to advocate for yourself and for your specific disease and what your community needs you to do instead of just complaining. So we're activism in the form of audio.
No, I think healthcare.
Wait, let it talk.
I just had a question about.
I'd like to note about we actually tried to have a more diverse panel, but everybody backed out, including Megan. So Megan, please talk as much as you want.
There wasn't a seat for me.
I didn't have to sit.
No, I'm kidding. But so it's a consumer. It's a curated network of podcasts. How do you become part of the podcast, and how do you become a podcast that is part of Offscrip
So
Health?
I'm looking at you through like this prism here. We have 5 business units. The first one, of course, is the documentary division, where we do these 8-part series, these 3-part series, highly production-driven, well-casted, well-produced, with this direct marketing to consumers. The second division is our network of individual podcasters that have weekly shows. Those shows are all funded in advance, which is another opportunity. Everything we do is prepaid by people who care that we can deliver 10,000x reach over their nonsense patient marketing budgets. So that's the second division. The third division is we produce white label content for other brands, almost like as a vendor to clients, because they don't want to be a podcast company. They don't know what they're doing. They're aware enough that this is not in their wheelhouse, so they come to us to do it for them. The fourth business unit is we are just getting into now listenership conversion as data acquisition. Is that more nerdy? That kind of resonates with this crowd. Listenership is the new data, because you can now prove that if you get 100,000 people listening to a show who are the exact listeners you need, and the entertainment value and the talent of that host and those guests tell you, time to get pissed, go do something, be the research, sign up here, and be the future, whatever you say. They'll do it. We are just now getting into I would say, because we wanted to prove like phase 1 was, can you get the people in the door? And we can. So the fourth business unit division is, can we get the people in the door to act and opt in and learn and sign up? That's the fourth. And the fifth business unit, which we're slowly moving into, assuming we finish our round and do all the other things, is becoming that data company that works with health systems who need the patients, let's say value-based care, opinion, satisfactions. We are a great recruitment tool than just putting an app in someone's phone or asking you to sit down and watch something when you have no time to do it. So that's how we're scaling.
All right. So I want to thank our panel. I mean, you guys heard from all of these guys, amazing people. I mean, we're very proud and happy to have all these fantastic founders and getting to meet the people who actually run the actual daily operations, like Matt. We are opening up a facility here in New York for anybody who's into healthcare. You need an office space, you want to do events, things like this. So down on 28th Street, I think we're going to wind up. I also run Happen Around Health 2.0 New York, also known as MedStarter NYC. It's been around for a long time, 7,500 members in the community. And we do events, usually we do events more like this. So anyway, so you can see like going from patient activism and being excited about fixing things to actually being involved in the companies as they grow. Our first exit was from Direct Shifts. It was only 13x, but we still have some of their stock and we're expecting even bigger things from them. And Matt's our third latest investment, so he's doing great. And And yeah, so if you want to talk to anybody or talk to us.
Awesome.
Okay,
you.
so I'll get off now. Finally.